All right. Well, I want to talk about the mechanism of action of psychiatric treatments. And I want to argue that we should stop talking about neurotransmitters. Okay, that's a little strong. I don't mean we should just stop completely, but I think we are thinking at the wrong level of abstraction when we talk about the mechanism of action of psychiatric treatments. So we spend so much time thinking about memorizing all the different receptors that our medications bind to. Are they partial agonists? Are they full antagonists? Are they reuptake inhibitors? Which neurotransmitters are they working on? So on and so forth. And I think that's just the wrong level of abstraction, and it's not going to push the field forward. And I think it's probably done some harm in the form of where we've focused our search in the pharmaceutical space because we discover a drug that works for, say, schizophrenia, and it happens to be a dopamine antagonist, a D2 antagonist. So we go inventing a bunch of other dopamine antagonists and try to fiddle with it, make it better. And for the most part, that just gets us a bunch of drugs that do about the same thing, not really any better. Most of the great things we discovered in psychiatry were sort of serendipitous. ECT could be put in that category. Clozapine could be put in that category. Lithium could be put in that category. There's very few things that were invented or discovered in psychiatry from a sort of rational design point of view by thinking about neurotransmitters and their receptors and all that stuff. And I think it's just because it's the wrong level of analysis. It's like trying to understand why Microsoft Word crashed by looking at transistors in the circuit board of your computer. Maybe there's something wrong with the transistors, and maybe if we flipped the right ones and zeros in the transistors, it might fix the problem. But that's just the wrong level of abstraction. The problem is at the software level, right? Not the transistor level. And that's kind of what we're doing when we keep spending so much time thinking about serotonin type 3 receptors or D2 versus D4 and all of that stuff. At the end of the day, all of our treatments are empiric treatments. And thinking about the heart, for example, if you have a supraventricular tachycardia and you try to treat it with adenosine, which slows down conduction through the AV node, are we going to say that SVT is an adenosine imbalance? Are we going to say that there is some adenosine receptor issue? No, because the heart is a much more tractable system than the brain, and we're able to understand that the atria could be fibrillating or quivering or fluttering or whatever, causing a supraventricular tachycardia, and that even if we're not able to fix the atrial issue, we can slow down the heart rate by blocking its or slowing down its conduction through the AV node. And so the receptor mechanism isn't really the right level of analysis there either, right? The right level of analysis for treating an SVT in this case is slowing conduction through the AV node. And perhaps that can be done through multiple low-level mechanisms, right? And in fact, there are multiple different types of treatments that have different low-level mechanisms of action that can treat a supraventricular tachycardia because we're trying to attack it at the appropriate level of abstraction. When someone has severe depression or psychosis, these are high-level phenomena, right? Because a lot of other basic functions are still working. If this was a very low-level phenomenon, like an ion channel was broken or a whole neuronal subtype was broken, then we would see much worse pathology, right? In those cases, when people have ion channel pathologies, channelopathies, you often get seizures and very global phenomenon happening. Or Parkinson's disease is caused by the loss of dopaminergic neurons, and you see quite profound cognitive changes and neurological changes. So when we're just seeing psychiatric manifestations, and these are relatively isolated from other functions of the brain, it seems very unlikely that studying low-level mechanisms are going to be the right approach. And this is interesting because some of our most effective treatments are often the quote unquote dirtiest mechanistically, right? Clozapine is the most effective antipsychotic, and yet we really don't have a great idea of how it's working from a low level mechanism point of view, right? It binds to many different kinds of receptors. It doesn't bind to dopamine receptors very strongly. It has lots of effects in the brain, and yet it's the most effective. Why is that? Similarly, ECT, electroconvulsive therapy, we're electrically stimulating the entire brain to the point of inducing a seizure. That's clearly not working at one type of neurotransmitter or one neuronal subtype. It's having global effects, and yet it works for a lot of different conditions. And things that have widespread low-level effects, like serotonin reuptake inhibitors, which affect the level of serotonin within hours of taking the medication, and yet the effects don't happen for weeks. Why is that? Why is the effect, when it does happen, potentially a couple of weeks later, it's a very small effect? So I think it might be more useful to think of the brain at a higher level of abstraction, similar to measuring heart rhythms, right? We have brain imaging like fMRI, we have electroencephalography, EEG, and while we can sometimes find changes in those studies between people with psychiatric conditions and healthy controls, it's often messy and often not very trustworthy because we're looking at very high dimensional data with a relatively very low number of patients in the sample. So it's very difficult to be sure that you're not picking up a spurious correlation. But with tools that allow us to actually probe directly certain parts of the brain, like transcranial magnetic stimulation and the emerging technology of low intensity focused ultrasound, we have a better chance of being able to actually try to figure out which part of the brain is, at least in a rough manner, going to be more useful in treating certain psychiatric conditions. So, for example, from neuroimaging studies and from clinical outcome with TMS, it seems fairly convincing at this point that some parts of the left dorsolateral prefrontal cortex are often hypoactive in some patients with depression. And by stimulating those parts of the brain and increasing the overall activity in that part of the brain, you can rescue the depression in a good portion of patients. And instead of asking what neurotransmitters and receptors we're affecting, what if we asked what combination of low-level effects would it take to achieve overall enhanced activity in the left dorsolateral prefrontal cortex? This is sort of similar to how we try to treat arrhythmias in the heart. We can say, okay, the atria are electrically dysregulated and they're sending too many impulses down to the ventricles. What are all the possible low-level moves we could make to stop that or slow it down? So anyways, that is just something I wanted to throw out there. And I'd be curious what other people think about that. You can go on the Substack, brandonbrownmd.substack.com, or just brandonbrownmd.com, and leave a comment.